Hello, my name is Raj Gupta, and I'm here with Dr. David Brown, who served as president of ASRA from 1999 to 2000. He received the Gaston Labat Award in 2004 and served as editor-in-chief of Regional Anesthesia and Pain Medicine from 1996 to 2004. This interview is part of the activities surrounding the 100th anniversary of the founding of the first American Society of Regional Anesthesia in 1923 by Gaston Labat and colleagues. Although this organization is not directly related to the current day ASRA Pain Medicine, which was founded in 1975, it has been said that the current society would not have existed quite like it does without the work of Dr. Labat and the original ASRA. With that, I want to introduce Dr. Brown. Dr. Brown, thank you for joining me.
You're welcome. You're welcome.
It's an honor for me to be able to speak with you and talk to you a little bit about this history. I'm a big believer in understanding and reciting history, the narrative history of an organization or a group of people, because I think we learn a lot from that. So I'm hoping and I'm looking forward to hearing your perspective on your experience with ASRA. And you've been obviously part of this organization for multiple decades and been a major contributor to both the field of regional anesthesia and the society. So my first question for you is, when you became involved with ASRA, what were the predominant needs or issues of the society at that time?
Well, like most societies, it had to do with income in versus expenses out. And so we were moving from a rather small organization to a much more expansive one. At the time, pain medicine became much more impactful in regional anesthesia and pain medicine. And so it was really about balancing the books and expanding our meeting venues so that there could be a little bit more of the three-ring circus and a little less of everybody gets funneled through the same lecture hall.
Do you feel like, or what were the predominant issues in the field of regional anesthesia, acute pain and chronic pain at that time in the actual medicine part of it? What was changing there?
Well, there was the tension, which is still present, of people that did full-time pain all the time. They got out of the operating rooms versus those that had a balance between operating room pain versus those that really still ran block clinics and really didn't provide a comprehensive pain approach. And then at the time I got involved, one of the most important things is all the 1975 founders were still sitting around the table often. And so convincing them that change needed to happen was also a big deal.
And what do you think they were holding on to at that time that you felt like needed to shift? Is it just that independence of or integration of the acute pain portion to regional and involved in the entire care of the patient, or was it more complicated than that?
A little more complicated. There was the natural tension. The one founder that really never gets listed as a founder is Dan Moore, and he and John Benika's a little bit fake controversy through the years, both in Seattle, and both were friends, but they like to play up the national controversy over how to do pain, how to do OR, and both were very talented physicians, but we're getting later in their career at that point. And I would not have done anything in the field without my time, the 5 years I spent going through Virginia Mason and learning really so much from Dan, from Gail Thompson, others that were there, Don Breidenbaugh. Don and I grew up actually in Nebraska, about 20 miles apart. And then his brother Phil was actually one of my primary mentors in the field, both academically and also in the specialty. I was Phil's first program director when he was president. I was his program director, and so he taught me quite a bit.
Do you think during that time you were in leadership with the board and at the journal, do you feel like ASRA moved the bar in the specialty and what was happening in the field of anesthesia as a whole? Where do you feel that the organization was taking a lead?
Well, one of the things we did during my time as the editor of our journal was I think I twisted Jim Rathmell's arm to lead part of the journal on imaging. I had the sense that I could see ultrasound coming over the horizon. I'd see the MRI, CT scans making big changes, fluoroscopy making big changes. And so we put a section in the journal called Imaging, and it was to try to get people to think, to use that rather than like many of us did early on. As example, I've probably done more celiac blocks without imaging than I have with imaging, just because of my age. And we now today would not think that's real good practice.
Yeah. And so this takes me back, or takes you, I'd like you to think back to earlier in your career. Regional anesthesia as a specialty was probably only whispered by a few early in your career. And there were a few centers of excellence in the country, but it was definitely not pervasive in anesthesia throughout the country. What drove you to focusing on regional and acute pain management early in your career? What was that spark?
Well, I needed a job after I left the Air Force. I needed a position, and I ran the visiting professor program in our Air Force residency in San Antonio. And Gail Thompson came through as a visiting professor. And I think probably a little bit offhanded, he said after I dropped him off at the airport, well, if you ever need, if you're looking for a position after you leave, I know you got a year and a half left, why don't you reach out? So I did reach out. And about a year before I left the Air Force, I had a job at Virginia Mason when my obligated time was done. And so that I was deep in the mill of, what we have, a dozen at that point, staff members out there, and almost everybody of note in the world at that point came through Virginia Mason through the visiting professor program. So we had very much a nice mix of opinion. Bupivacaine was relatively early in its widespread clinical use. We had some troubles with that, but we had done, I think at one point, Virginia Mason had done 80% of all the bupivacaine injections in the world at one point in time. So we had quite a bit of experience. Randy Carpenter, who had done his fellowship at UCSF, came back and put some science to some of that. And it was just a lot of strong-willed, opinionated people that were really good clinicians. I think that's the thing that I recall about this, is they were people of goodwill, not without opinion, but they were of goodwill, and they had pretty good hands. And so a lot of that stems from Dan Moore, Don Breidenbaugh, setting up the structures underneath it.
For those of us that have come into the field much later, we take certain things for granted, both from a clinical perspective, safety perspective, technology perspective. How would you say, you mentioned bupivacaine sort of introduced in your career, how would you say the field has evolved over your career? Like, what do you see as the big changes from when you started doing regional or acute pain management? Where do you think the big changes have been? Obviously, there's always a little bit of back and forth that happens. People are trying novel things. They sort of become fads and disappear, but some things have been revolutionary, evolutionary changes. What do you see as you reflect back?
Well, I'll tell a little story about a resident I had at an unnamed Midwestern institution who was one of my residents. And I told him after we worked together in the block room one day, I said, I don't think you should ever do regional anesthesia again, because he saw the world in two dimensions, and he didn't have that ability to see that third dimension, what was below the skin. And I think in some sense that artistic quality is now been replaced a bit with the technical quality of looking at the ultrasound all the time and kind of missing the patient sometimes. And I liken it a little to my days in aviation, where if you get off and get tunnel vision on your instruments, you might go the wrong way because you've lost the big picture. You've lost situational awareness. And I think that's a key element in our practice, because we still have, and now, to be fair, I'm more of a patient than I am a physician. I've often after I've had a pretty serious illness a decade ago. And I often said, I've got a physician brain, but I've got a patient's heart. And actually, as a patient, what we want from our physicians, especially those sticking sharp, long things into us, is we want them to see us in the picture. And so that sense of caring, that sense of calming, that sense of great bedside manner can be lost a little bit when everything is in a sleeve and well, give me the ultrasound and you just forge ahead. It takes a little bit of that soft touch that you needed before the advent of ultrasound. And also, you got to be pretty good at sedation. Some of the drugs now make that almost mindless. I mean, you stop and think about propofol and some of the things that go on. It's wonder drugs compared to what we had when it was Valium and morphine. So.
I was reading with interest the article that you sent me on Gaston Labat. You guys did this was an article from 1992, I believe, where you did a history of his life. And there was a comment that you took from one of his texts about the value of the anesthesiologist providing calm to the patient and reassurance, and how you speak to the patient, the words you choose affect their impression of the situation and their anxiety level. I frequently tell my trainees that your most powerful anxiolytic is your tone of your voice and the manner in which you speak, more often than the drugs that you give. And so I definitely identify with that comment of yours, that we have to maintain that skill set as we get more technical and technological with this.
I think and it's that way in medicine in general.
Yeah.
I mean, as you see oncologists now, it's all about the algorithm, and they still forget, but guess what? I'm still here. And so I think medicine in general, our physicians are suffering a little bit from being commoditized, and that sense of being an artist a little bit lost. I tell a little story on Virginia Mason. When you went out there, you got fitted for tailored scrubs, and they all had our names emblazoned across the front pocket and the back pocket on your hip. Your name was on there. And so the scrubs were tailored to you, your size. And that was Dan and Don elevated the practice to a level that had a great deal of respect. And they often, they taught so well. The only person that should know that your block isn't 100% is you. Patient shouldn't know, surgeon shouldn't know. And that helps regional anesthesia succeed.
Who do you think, I mean, you've mentioned many people, who do you think are some of your greatest mentors, really changed your career or influenced your career?
Well, I mentioned the Breidenbach brothers, both Don, who was the senior, and Phil, the younger brother, and they always called each other by that. It was Brother Phil, Brother Don. And growing up in Nebraska, like all three of us did, you could understand that. But Phil had a big impact on me, even though we never practiced together, because I sought his advice. He was very helpful to me as I considered other academic opportunities. And he was also ASA president. And the fusion between his leadership of ASA, while he was not far off from being ASRA president, was very powerful to the field, because the 90s, there were a lot of people that were, subspecialty care was really exploding. Pain was really developing. People were focused on that. And the big specialty, the ASA, was wondering, how do you keep everybody in the fold? Well, Phil did a great job of that. And, again, I think I may have mentioned earlier, the thing I thought about all the people in the world, in the European Society of Regional Anesthesia, ASRA, we had a very cooperative relationship. And I'd say the people both in Europe and in the US and North America and Canada, other places, Latin America as well, they were pretty nice people. People seemed to go into regional anesthesia because they really did care for patients. They wanted to relieve their pain. And what better is that? And as a patient, I can tell you, there's nothing better than having somebody relieve your pain, whether it be acute or chronic. And those have diverged. The 90s were also spent when Brian Reddy and colleagues at the University of Washington really took the acute pain programs and put some structure underneath them. So now almost anybody of credibility has a pretty good acute pain program, which was not present really much before the late 80s.
I think that when you think about ASRA as an organization, there's a lot of words that come to mind. It's for me, and it's been a very influential to my career. Could you think of some words that you would use to define ASRA as a society? Obviously, you've seen it over many decades, and it's probably not one thing over that time. But what comes to mind when you think of that society, as opposed to some of the other societies in our field?
As I mentioned earlier, I saw it as a worldwide group of colleagues who were really nice people, who had immense clinical common sense, and they had pretty good hands. And weren't afraid to tell you they had pretty good hands.
I think that needs to be our new logo. Is ASRA Pain Medicine. We got pretty good hands. That may be the new brand for the organization. We'll have to talk to somebody about that.
No, I think the collegiality. Brendan Finucane is a good friend. There are so many in Europe that were good friends. Many now. The founders pretty much of the 75 Society are gone away, but pretty nice people. And they took an idea, brought it up, put stuff around it, and they picked the right people to put around it. And people are what drive this for you. But if you don't have the patient in the crosshairs really focused, it's not going to succeed. But and we have very close contact. I mean, think about it. Usually, if you're doing an OR anesthetic, you got an IV between you and the patient. But when you're doing regional anesthesia or pain medicine, you got your hands on the patient somehow, protecting the patient from your needle movements or whatever it is you're doing. There's a very relationship. And then we also went through all the opioid epidemic. I guess I was still perhaps president of ASRA. I was editor in chief. I got subpoenaed to Florida for the first real high profile OxyContin pill mill case. And I asked my hospital attorney, could I turn this down? He says, I don't think so. And so I ended up going to a small town, and that particular physician ended up getting 65 years for running an oxy pill mill with lots of deaths. So, we lived through all, and are still living through that. We're living through the negative side of patients not being able to get opioids when they actually need opioids due to the fear. So it's changed a lot. The regulatory hand is heavier than it used to be, but individual patients still love their physicians if they care for them and relieve their pain.
I have two last questions for you. So one is, if you could think back to some of your best moments with ASRA, do you have a funny memory or something, a humorous memory you can think back within the organization, or your experience at the meetings?
Well, I remember a meeting in San Francisco when I had just moved to Virginia Mason from the Air Force. I was green as green could be, but we'd done a bunch of celiac plexus work, and I was presenting at an ASRA meeting, and Al Winnie was in the audience, and he asked me a question, and I knew his paper better than he knew his paper, and I said, well, Dr. Winnie, in your paper X, Y, and Z, you said, and that stopped the question. And so it's the old story. You don't want to ask a question you don't know the answer to.
Right. We have since I've been involved with the organization, one of the missions of the organization is to make sure that we mentor and bring young members into the society. and build them up, give them opportunities, and hear their voice, and to give direction to the society. As somebody who's seen the society for many decades now, what advice would you give to those young members? Where do you think that the organization needs to go, that they should be focusing their energies on?
Well, don't get hung up on a technique. Get hung up as a young person on a disease process or a patient population. Keep it focused on the patient, because we might find out that some sort of supervision comes along and makes ultrasound obsolete. So you don't want to make your name completely on ultrasound. You want to make it on imaging to improve regional anesthesia. Or how do you take care of patients with pancreatic cancer? When I got into that at VM, it had kind of become passé. A lot of people were worried about neurologic injury from it. And we ended up actually doing a fair bit of work to underpin why there was neurologic injury. But so don't hang on a technique, because those can become, leapfrog. Pick a patient, disease process, something that actually won't change no matter what. And then as a society, test those young people. You have to try them out. Some of them are very talented, and some maybe better stay in the operating.
Yeah, but you don't know until you try.
No, that's right.
Yeah.
That's exactly right. Yeah.
Any last comments or thoughts that you want to share with the people that are going to get to listen to this?
No, just enjoy it, because it goes pretty fast.
Yeah.
It goes really fast. And and there's nothing more beneficial, than having people tell you that you help them in some fashion, learning some part of our profession.
So, Dr. Brown, if you could think of some singular words to describe the organization of ASRA Pain Medicine, what kind of words come to mind when you reflect back on your experiences?
I guess the thing that would most center in my mind is common sense, artists who loved patients.
It's been a real pleasure and a joy to get to speak to you again and hear about these experiences that you've had with this society, this organization, and obviously this field of medicine. You've been a great influence to a lot of people, and a mentor to many, many. And I think that your legacy is definitely quite permanent in the organization. So thank you so much.
Well, thanks for having me.